and this is the aorta. They're almost identical in size, but it's very clear aortic override. If I do a pulse Doppler and it's normal, I will still say wait and see, but I'm much more suspicious about this baby than the previous baby. This baby is the next one, which is getting more and more obvious. The 4th chamber looks normal. When I look at the 5 chamber, I can see there's very obvious aortic override. And I say to myself, this looks like tetralogy of Fallot. I say, well, hang on. When I look at the 3, when I sweep from a 5 chamber view, I see a pulmonary artery that looks normal. Laminar flow, aorta, as we see. And the pulmonary artery is bigger than the aorta, as we see. I say, is this another VSD? No, this has to be Fallot's. Then I do a pulse Doppler gate, and I get velocities which are greater than 100 centimeters a second. That baby has got tetralogy of Fallot. So you understand there's a spectrum I'm walking you through. On each case I'm sure you're going to get worse and worse. And you need to understand the steps you need to take to distinguish between them. Very quickly, this baby has got aortic override. This baby has got turbulent flow with the VSD, and the aorta now is bigger than the narrow pulmonary artery. And there's obstruction, infundibular obstruction. That baby has got an obvious tetralogy of Fallot with mild pulmonary stenosis. How do I know? Because when I look at the Doppler across the aortic valve, I'm getting velocities of 40 centimeters a second at 20 weeks. And I compare it to the pulmonary valve, I'm getting velocities of over 100 centimeters a second. That baby has got pulmonary valvular stenosis with aortic override, turbulent flow, with a mild discordance between the great arteries. The next group is moderate pulmonary stenosis. Everybody in this room can make this diagnosis. So we look at this baby, you see the aortic override here, and the intraventricular septum, and here's the valve. You say, Simon, how can you be sure that this is a tetralogy? When I look at the pulmonary artery, it's coming out of the right ventricle, but the pulmonary artery is much smaller than the aorta. So this is a moderate degree of pulmonary stenosis, and the velocities are 125 centimeters a second. Very obvious fellows. And when I look at color Doppler on the 3-vessel tracheal view, I see the Y configuration, the dilated aorta, and the narrow pulmonary artery. Tetralogy Fallot. This is not double outlet right ventricle. This is not a common arterial trunk. And then I stick volume assessment of the same baby. I see the branch pulmonary arteries. I'm going to monitor this baby by taking Z scores of the main pulmonary artery and the right pulmonary artery and the aorta throughout the pregnancy. Because somewhere between 15 to 20% of babies will progress from mild to moderate pulmonary stenosis to pulmonary atresia. You asked me today the question, Simon, when do I look at the short axis? This is an example that I have to look at the short axis. This is the tricuspid valve. This is the Mercedes-Benz of the aorta, and this is the pulmonary valve, and this is the right ventricle. This is the view you want to get in every baby with tetralogy of Fallot, because you want to work out, is there a band of muscle that's extending and blocking and obstructing the right ventricular outflow tract? Because when the surgeon operates with this knife, he cuts out this muscle, and you can see it prenatally, but only on a short axis view. So when you look at this band of muscle here, just right below the pulmonary valve, which is here, and it's right in the direction obstructing blood flow, that's a classic tetralogy of Fallot with pulmonary stenosis. When you're struggling seeing the pulmonary artery, you can see a branch pulmonary artery. Sometimes it's very hard to see the pulmonary arteries. Then I use slow flow. And I use slow flow and I turn my balance down very, very low. And it gives me beautiful definition of the pulmonary arteries. So if you are struggling with color Doppler or power Doppler, remember slow flow technology and reduce your PREP, and you'll get a very clear demonstration of your branch pulmonary arteries. Your Y configuration, again, a very useful marker in the first trimester. It is also useful in the second trimester, but you've already made your diagnosis on a 5-chamber view of the heart. Next group is tetralogy of Fallot pulmonary atresia, and I said this is a terrible diagnosis. Untreated, 50% of babies die by 1 year, and 80% of babies are dead by 10 years. It's a terrible, terrible prognosis. Because if you do have native pulmonary arteries, you have to put a shunt from the right ventricle to get to it, because there's obstruction in the pulmonary artery. So if you take a 4-chamber view of heart, and you have your right atrium, so this is your tricuspid valve, this is your mitral valve. You basically want to get your right ventricle to connect with your branch pulmonary arteries, because there's no flow coming across. The only way you're going to be able to get a connection between the right ventricle is by putting a Gore-Tex shunt in. And a Gore-Tex shunt doesn't increase in size as the baby grows. So you have to go back in and have a second operation when the baby's bigger, put in another shunt. Third operation. Most babies with pulmonary atresia, with tetralogy valve, will require a minimum of 4 shunts before your final shunt is placed. So that's why it's such a terrible prognosis. Graphics, left axis deviation, and right aortic arch. This morning we had a case very similar, but once you see that, that's a typical pulmonary atresia. They have a big VSD, they have an atrial primum secundum septic defect, and the aorta is much bigger than classic fellows, and then there's no flow. That's the typical appearance. And flow comes out the aorta, down the reversible flow and into the pulmonary arteries. And then this baby comes off the descending aorta. On ultrasound, you do a 4-chamber view of heart, there's actually left descending aorta, and you can see there's a VSD, and you can see that there's aortic override. You then sweep up, and you get the aorta, and then you can see the reversible flow. The vesicle plus, the trachea, the transverse aortic arch, is the SVC. And there's a reversible flow, and you know exactly where to look for the reversible flow because of golden rule number 2. Trachea, SVC, aorta. You know that the arterial duct is to the right of the aorta. That's why these rules are so important, because I know where to look to see where there's reversible flow. And then I go onto a sagittal section and see the big dilated aorta, and then I see the reversible flow. So in a sense, I have to track the reversible flow, feeding the pulmonary arteries, knowing that the baby is going to get blood flow by native pulmonary arteries. Sometimes when you look, it can be quite a circuitous duct which feeds into the branch pulmonary arteries, but it's important. And if you cannot see native pulmonary arteries, you look at the area behind the heart, number 1. So there's a hypoplastic right heart in this baby. Or you look at the descending aorta. It's the first trimester scan, looking for multiple collaterals. These are bad prognostically. I've already mentioned absent pulmonary valve syndrome. I've spoken about that's a very straightforward diagnosis. And I'll finish up by talking about first trimester fellows. So in our practice, most babies with tetralogy fallow are not picked up in the second trimester, but picked up in the first trimester, because either they present with an increased glucose translucency, they present with a left axis deviation, they present with a right aortic arch, and on the 3-vessel trachea view, they have the Y sign, and they also have the question mark sign. So all these signs in the first trimester are very powerful